I'm Kathryn Power, the Director of the Center for Mental Health Services within the Substance Abuse and Mental Health Services Administration, which is, of course, part of the Department of Health and Human Services. I'm really very pleased to be included this morning to discuss the prevalence and impact of childhood trauma and to share the good news that prevention works. I'm addressing you today not only as a mental health professional, but also as a mother, a former teacher, and a lifelong victims' rights advocate. I started working in my career as a counselor in a rape crisis center. And ever since that time, I think that's been sort of the driver for me in terms of looking at how people deal with trauma and how they heal from trauma. The mental and physical health needs of trauma survivors, and especially our nation's young people, have really informed my work for the last 30 years. In our efforts to support trauma trauma survivors of all ages, we first have to start with the fact that we have to recognize that trauma is not a disease. Trauma is a public health issue that affects the quality of lives of individuals and their families and our nation as a whole. We cannot hope to not only support people in their emotional lives, but also to rein in health costs and to improve health care if we don't attend to trauma and its consequences. Trauma occurs when an external threat overwhelms a person's coping resources. Interpersonal violence, including physical and sexual assault, such as rape, incest, battering, and murder, shatters trust and safety, fragments relationships, narrows hope, and impedes recovery. Children growing up in the United States today face a surprising level of violence, including child abuse, witnessing domestic violence, crime, and bullying. An estimated 3 to 10 million children witness domestic violence every year, and more than a third of adolescents between the ages of 14 and 17 have seen a parent assaulted. Children are also the victims of violence. Every 35 seconds, a child is abused or neglected in the United States, and every 6 hours, a child dies from abuse or neglect. 1 in 5 girls and 1 in 10 boys are sexually abused before adulthood. And in one study, 92% of incarcerated girls reported sexual, physical, or severe emotional abuse. Childhood experiences of abuse and neglect are not only common, they are highly destructive, even years after they occur. As Elizabeth pointed out, they exert a powerful impact on adult emotional health, physical health, and major causes of mortality in the United States. And trauma is intergenerational. Parents' own trauma histories are risk factors for negative parenting behaviors. Higher levels of exposure to trauma lead to decreased parenting satisfaction, reports of child neglect, psychological aggression, and a history of Child Protective Services reports. Of particular importance to the future of American competitiveness, the more adverse experiences a child has, the more likely he or she is to have serious job problems as an adult. And the costs of untreated trauma are astounding. A study using 2008 data shows that the predicted incremental cost of untreated trauma to the healthcare system alone ranges between $333 billion and $750 billion annually. In the past decade, a new understanding about the impact of trauma stemming from violence has begun to fundamentally alter the way services are delivered. Since we now approach trauma as a public health issue, we know that it can be addressed by creating safe, stable, and nurturing environments for children, youth, and families. As a result of the ACE study, and also as a result of SAMHSA's Women and Co-occurring Disorders and Violence study, we have begun to view individuals and their behaviors through a very different lens. The SAMHSA study on women and violence highlighted the extent to which trauma can actually become a central organizing principle in a person's life, affecting her ability to form relationships, to keep a job, or live in stable housing. Our study made it clear that many individuals previously labeled as mentally ill, substance abusers, or criminals were coping with the results of severe trauma histories. This understanding helps us interpret much of what we once considered pathological behavior that Helga mentioned, such as IV drug use or self-injury, as coping mechanisms that allowed individuals to survive unspeakable acts. These coping mechanisms develop at a very early age. Children exposed to violence may act out or withdraw. A child who is getting good grades may fall behind. One who has many friends may become isolated. It is perhaps not surprising that mental, emotional, and behavioral disorders are common even among very young children. About 1 in 5 children will have at least one such disorder, and many will have more than one. Parents often report concerns about emotional and behavioral problems before age 5. I remember there were people that scoffed at the term, infant mental health, scoffed at that term. We must stop the cycle of violence and abuse and help our children and their families learn healthy coping mechanisms that allow them to bend rather than to break in the face of life's adversity. This is the very definition of resilience. And the good news is we know how to do so. The good news, Brian in Illinois, and here we are in Wisconsin. The good news is we are doing things, and they work. A growing body of research has demonstrated that there are effective strategies to promote healthy development, enhance social and emotional well-being, and prevent and reduce a host of behavioral health problems. In 2009, the National Research Council and Institute of Medicine of the U.S. National Academy of Sciences published its groundbreaking report. It was called Preventing Mental, Emotional, and Behavioral Disorders Among Young People. That report was commissioned by the Center for Mental Health Services at SAMHSA. The 2009 IOM report made 2 very important contributions to prevention science. First, the report noted that many mental, emotional, and behavioral disorders, including substance use and abuse, can in fact be prevented. Second, it pointed out that programs that include the promotion of sound mental health should always be a part of the full range of mental health and other health services. The report outlined very effective programs that prevent mental, emotional, and behavioral disorders from developing and, in fact, promote emotional health. The IOM report fits very squarely in adopting a proactive public health approach to healthcare. Indeed, I believe we truly have reached the tipping point where you hear today everyone is ready. Policymakers, health and mental health care providers, and the general public itself are increasingly understanding that behavioral health is essential to health. Implicit in the public health model is the identification of risk and protective factors. Prevention programs emphasize the avoidance of risk factors, and some risk factors such as poverty, child maltreatment, family dysfunction, and exposure to violence predict multiple negative outcomes. This means that interventions that target these risk factors result in beneficial outcomes in multiple areas of a child's life and in multiple systems and sectors within society. It also means that we must attend to the broader social and economic conditions in which children live. Increasingly, our communities are stressed by the crisis of poverty. The authors of the IOM report wrote that we are persuaded that the future mental health of our nation depends on how the costly legacy of poverty is dealt with. Poverty often results in overcrowding, poor schools, limited health care, unsafe and stressful environments, and lack of adequate food. All of these risk factors can imperil cognitive, emotional, and behavioral development. Because half of all lifetime cases of diagnosable mental illness begin by age 14, and 3/4 start by age 24, interventions targeted to young people show the most promise. In addition, symptoms precede onset of a full-blown condition by almost 2 to 4 years. So that means we have an important window of opportunity in which to respond. Evidence-based interventions aimed at family functioning have been shown to reduce aggressive, disruptive, or antisocial behavior, improve parent-child interactions, and prevent child maltreatment. School-based social and emotional learning programs may improve academic outcomes, and violence prevention programs have demonstrated success in preventing violence and risk factors for violence. Our Safe Schools, Healthy Students initiative, which is a joint effort of SAMHSA and the United States Department of Justice and Education was recently cited by the White House as one of the 3 model programs that uses a community approach to prevent violence. Many of these programs are quite simple and easy to implement. For example, SAMHSA supports the dissemination of what is known as the good behavior game. Classroom teams are given small rewards for positive behavior, such as being on task or displaying cooperation. The good behavior game has been shown to increase academic engagement and reduce disruptive behavior. Over the long term, it reduces the development of conduct disorder, substance abuse, and suicidal ideation. Most evidence-based prevention programs have been shown to produce far more benefits than they cost. This is significant given the fact that costs associated with behavioral health problems in young people in 2007 dollars were estimated at $247 billion. In addition, there are some key elements or kernels of evidence-based programs that can themselves be implemented by individuals, by families, by schools, and by whole communities. For example, giving verbal praise to acknowledge and reinforce desirable behavior can improve cooperation and social competence and reduce disruptive behavior. Supplementing your diet with omega-3 fatty acids found in fish and nuts is associated with a reduction in aggression, violence, and depression. And providing children with meaningful roles in school and at home can help build self-efficacy, enhance family functioning, and decrease negative behaviors. Helga said that no one organization or federal agency can do this alone. The effects of trauma spill over into our hospitals, our jails, and our social welfare system, and these organizations must be a part of a comprehensive solution. We are so pleased at SAMHSA to be committed to leading efforts at the federal, state, and local level, along with leadership like Commissioner Samuels at ACF, to develop and disseminate trauma-specific interventions and trauma-informed principles and practices to help promote mental health, well-being, and healthy relationships among trauma survivors and their families. SAMHSA will embark on a national trauma campaign to raise awareness of the behavioral health consequences of trauma. Among the goals of this campaign are to prevent the cycle of abuse, trauma, and behavioral health challenges across generations among those who have experienced a traumatic event. Using messages of empowerment, resilience, hope, and compassion, we hope to promote healing and recovery for families with young children by supporting behavioral health services and supports that are trauma-informed. We have started this important work. In 2001, as authorized by the Children's Health Act, SAMHSA funded the National Child Traumatic Stress Network. The network's mission is to use empirically supported strategies to improve access to services for children, their families, and communities throughout the United States who are impacted by violence and trauma. Today, that network includes more than 130 medical, universities, academic-based research facilities, and community service agencies. They work in schools, child welfare agencies, community mental health clinics, hospitals, juvenile residences, and dependency and delinquency courts. Network members have succeeded in increasing awareness of the impact of child traumatic stress, providing education and training, and developing resources to enhance the knowledge and skills of behavioral health staff. Last month, SAMHSA announced 15 grant awards totaling $7 million over the next year to improve services available to children and adolescents who have experienced traumatic events. Treatment and Service Adoption Center grants will develop the best methods for preventing, screening for, and treating behavioral health problems that may result from traumatic events. Community Treatment and Services Center grants will support the delivery of trauma-informed practices and interventions to children and adolescents in community-based settings. We do not have a moment to lose. The gap is substantial between what is known and what is actually being done. The authors of the IORM report believed that the nation is now well positioned to equip young people with the skills, interests, assets, and health habits needed to live healthy, happy, and productive lives in caring relationships that strengthen the social fabric. This can and it should be the vision of the future of health in America for all of our children. The time to begin is now. Thank you very much.